Good afternoon, everyone. Welcome in. I'm going to give it a second or two to let you guys get in and get settled. Okay, great. So good afternoon, everyone, and welcome to the CE Learning Library Extended Q&A Session 4, From Intention to Action, Empowering Patients on GLP-1 slash Incretin-Based Therapies. I'm Leslie Samay, Director of Professional Development at Great Valley Publishing, and I'm your host for today's session. So today is the first of what we hope will be many more to come, fun, informative, and interactive discussion sessions. Today's session is meant to be an informal conversation with one of the subject matter experts from the June 5th webinar on GLP-1s, Dr. Nina Crowley. Dr. Crowley is a devoted advocate for improving communication, patient-centered care, and accessibility in obesity care. She's a PhD in health psychology from Walden University, an MS in healthcare policy and management from SUNY Stony Brook, and a BS in nutrition science from Cornell University. So she is the perfect person to help us through today's conversation. So while today we want this to be super interactive, we also want to make sure that everyone's voices, as best as we can, are heard and your questions are answered. So whether it's between you and Nina or you and your fellow attendees, you can raise your hand in the Zoom menu at the bottom of your screen, or you can use the chat box. We want to hear from you today, so feel free and join in with your thoughts and feedback. If you'd like to interact live, raise your hand in the reactions button and I will unmute you and then I'll say your name and then you can participate live by asking Nina your question or provide your comments that you have for today. Try to get to as many as we can, but doing this kind of sort of process will help us keep the interaction somewhat orderly. We're going to start off with a pre-selected question. Unless somebody has something burning, please put it in the chat now, but we do have a pre-selected question from our previous event that we will read aloud and Nina will address. And finally, while there are no handouts, the session is being recorded today and we will post it on the CE Learning Library for you to access in a few days if you want to go back and listen in. So with that, Nina, let's get started. We have
Awesome. Hey,
first,
everybody.
our first question today is focused on clinical counseling and communication. So what are some strategies, Nina, for explaining that there is no quote unquote quick fix or lifestyle and that lifestyle changes remain essential alongside GLP-1 medications?
That's a good one. And now this webinar feels so distant. So I'm glad everybody's on here. Hopefully you can unmute yourself and talk to me this way too. I'm trying to peek through the list to see if I recognize anybody. But yeah, in counseling, I think, one of the things that I find the most interesting, and we talked about this a little on the webinar, is just how similar the counseling is to our surgical patient pathways. So for those of you who did or who do bariatric surgery counseling, there's so much that we can apply from that patient population to our folks who are taking medication for obesity or even for other conditions related. So I really, in the counseling mentality, there's a lot around not talking about this medication is going to fix anything, right? And a lot of what we do, I had this conversation actually over the weekend in a different context about how people come to us asking, like, hey, here's what I want. Can you give me a meal plan? Can you tell me the advice, right? I completely made the mistake of sitting on my international flight to Italy a week and a half ago and telling the person what I did. I'm like, that's such the thing you don't do. You don't tell them you're a dietitian. So she's like, oh, well, you'll love this. I'm a clean eater. And I da da da. And she starts unloading stuff from her bag as I'm like, putting my burger from the airport away. So, I think there's just such this connotation of like, you're going to be on medication and it's going to change everything. I mean, I will say that the messaging around medication these days does make it seem that way. And one of the things that we talked a little bit about in the webinar, we didn't get to dive in so deep, is on the non-responders, right? So there's a lot of energy around people saying, weight's falling off, weight's, coming off so fast, and they're just, people aren't hungry and they're not having food noise and all of that. Those are all great things for most people. I do think it's important that we use our words and our language in our counseling to talk to people about. That is a response that some people have. I think it's important maybe even to show graphs or numbers or data on people losing weight and all these other sort of comorbid conditions at different rates. Because if you're in that group as a non-responder and you're not having that experience that everybody else is having, that's especially like, I don't want to say traumatic, but kind of, because you're not seeing that. And so I think that part of that is just the medication is part of your pathway. It may be here for long term, it might not. As many, as much as we want to talk about meds being part of someone's long term plan, and once you're on something that helps you lose weight, you'll probably have to be on that forever. We know that insurance changes. I mean, even just think of your own situation with insurance, how often that changes, and how not just supply and accessibility and all of that can affect it. So the quick fix mentality, I think, is something that we all are working on all the time to kind of come away from, and being able to talk about you're my patient lifelong. You're gonna have a team hopefully around you always, and we're gonna ebb and flow. We're gonna react to how things are going in your weight journey. Um, so I am glad now we've got a couple questions in here. So Elaine has a question about microdosing. I think microdosing is really interesting. From a lot of the professional associations, they're really not, recommending that as because it's off label, right? Um, and I heard actually at this trip I was just on some people talking about microdosing, and what they were talking about is actually just taking the lowest dose of Ozempic for diabetes, actually, and calling that microdosing. So I think that there's this big, like all the trigger words and the key words that people like to use. People like that word because it sounds like, well, I don't need that much. I would actually kind of add the frame that that kind of is still in the weight bias category, right? Of like people not wanting to, quote, admit that they're taking something to help. I actually just saw maybe this morning that like Andy Cohen had admitted that he had been taking a medication for something, right? So all of the language around admitting, you know, uh, all of that serves to really put people back in a quiet, shameful space of that, like, oh, you need help for this. Well, I don't need the full dose. No, I'm just microdosing it. So I think that there's a part of that. But I've heard a lot of, well-respected clinicians saying, like, yeah, it's just like any other medication, that lowest dose might be too high for someone. And so for the right patient, they might need a lower dose than the prescribed clicks of a pen or dose of a certain pen. So I would say we're gonna probably hear more and more about that. And personally, I know, I haven't wanted to come out in any kind of a all or nothing way of like, this is horrible, this is great. Similarly to compounding, we didn't talk too much about compounding, but I had a pretty strong view from a patient access and advocacy place working with the Obesity Action Coalition about, we advocate for care for medication, access to all that, need or want it need and want it. And at our most recent meeting that we had in July, there was a lot of patients from the TikTok community who have a large following of patients and who were taking medication in some way, shape, or form. And they talked about how they were very turned off by the OAC coming out with a statement and it seemed anti-compounding. And I hadn't really taken that patient perspective to heart and what that means for them. Like they had an access to a medication and it felt like we were taking it away from them by advocating for no compounding. And so similarly to microdosing, it's like I think we just don't know enough yet to really come out is like adamantly one way or another on that. um, and then I'm looking here, follow-up question from Elaine. Have you seen anything on a certain percentage of people who appear to be super sensitive to peptides, alters their energy level, even on the microdose? I haven't really. I think I know almost everything seems to be on a bell curve. So I do know that, in the studies, part of what's so exciting about this class of medications is that there's just so many more people who are at the higher end of response, but I know that there's many who are not. And so, I don't know the sensitivity to that. What I do feel like is important is that we are getting more and more options, that the people who are not responsive to one of the two, kind of right now, the big two that are out there, that they will have options down the pike that that they are responsive to. And so I also think we shouldn't forget all of the other medications that, may have been good options in the past. And maybe even someone who lost a certain amount of weight on medication or even with surgery, they could be, a good candidate for some of the older, non-GLP-1 based medications for weight maintenance even. So I'm seeing more about that. So again, I think what's really cool about it is that we, um, are looking at options. We're looking at individualizing and personalizing it to the person in front of you. And that for sure takes into account their access, their, interests, their goals, and all of that. Okay, Jessica asks, what concerns and how might you counsel patients using the compounded GLPs from an online program? So I guess I'm assuming most of us on here are RDs, but I won't say that that's 100%. But from a registered dietitian perspective, I think if you're counseling a patient that is on one, that means they've somehow found you, whether or not that program is offering comprehensive care or not. But that's the biggest message that I have around the compounding meds, is that often you seek them out, they provide you the medication, and sometimes it's on you as the patient to sort of arrange your care team. So if they've found you and you're a healthcare provider, that's great. At that point, it's kind of patient autonomy, right? Like they've hopefully had that conversation with someone on the team from a medical perspective, that risk and benefit. I think that's why, risk and benefit of medication is so interesting too, because for someone who only is like needing to lose 10 pounds or something, or wanting to lose 10 pounds, that risk benefit might be out of whack. And I think that's where our concern is for, maybe the celebrities or the people who are very public about losing a small amount of weight, that maybe those risks are higher than the benefit. And could that person lose 5 to 10% of their weight with diet and exercise and other, behavioral based programs without the medication? So I guess I would talk, make sure they have other folks on their care team. If they're not, and you're talking to someone who does not have that comprehensive team, there are a lot of virtual comprehensive programs out there led by obesity medicine providers with dietitians, behavioral health, exercise, all of that. And I would connect them to one of those type of programs. I'm happy that there's more of those. It's just, it seems like in a time where patients are less able to make those connections, we're putting a lot on the patient to have to assemble a legit care team around the medication that they're getting from maybe a less than legit method. Okay, Laura, what is the source for the graphs you mentioned to show weight loss on GLP-1s?
Nina, I put the references in from the
Oh,
June webinar in
perfect.
the chat. So if you all want to download those, I know there's a ton of data, especially the most recent paper that came out in May that you guys covered on the live show. So I think that covers that question.
Perfect. Um, And then I'd like to hear your thoughts on working with patients who want to go off the medication because of money. Yeah, I think that's actually a good conversation to have up front, is sort of, the philosophy that obesity is a chronic disease. As much as I think that we've known and been talking about this for years, it feels like it's finally becoming a little more, there's a little bit more people listening to it. But then, I'm referencing this vacation I just went on. I was with a whole bunch of people who were in healthcare and non-healthcare people, um, with lots of questions about GLP-1s. And it really was an eye-opener for me that I've been in a little bit of a bubble of working around people who get it. So when I'm exposed to like the general public questions, I'm like, oh, we have to really start back at, addressing bias against weight and size. And we have to really talk about obesity as a chronic disease, and that, whatever analogy I think works for you to talk to folks about, hey, when you have high blood pressure, maybe they talk about diet, but they pretty early on put you on medication, and maybe one, maybe two, maybe three, there's a whole conversation about spectrum of care, with diet and exercise being part of that, but not the only. And we don't, in really any other condition, make people prove that they have to go through diet and exercise and have success before you give them the effective medical treatment that is related to the success. So So part of this is, I think, framing the nutrition component as it's critical at any level of any person who's struggling in some way with their weight. Um, and it's just at, kind of what level you're when you're getting involved and what that relationship is. So counseling someone who wants to go off medication would be to expect some level of weight recurrence, is what we call it, rather than weight regain a lot of times, because it's a chronic disease. And when you take the treatment away, the thing that you're trying to treat may come back. And in this case, it's excess weight or excess adiposity. The tricky part with weight, of course, and you guys know my angle with body composition is that if you lost weight and it was mostly fat, you can't guarantee that if you gain it back, it's also going to be in the, the right ratio, right? So people tend to gain back more adipose tissue than they do muscle mass, unfortunately. So, there is some risk of, doing that weight cycling if people are only on it for a short period of time. And so I haven't really thought about the conversation of, is it worth going on it if you know you have to come off of it? Because that's a tricky question, right? If you know that you're going to have is it better to have a period of time at a reduced weight status if you regain it as fat? I don't know. I think that does, kind of, for me, support the need to look at someone's body composition to be able to tell that. If someone's at a very low muscle mass to start, I'd be a lot more concerned with them than I would someone who has a, pretty high degree of both fat-free mass made up of muscle and their fat mass. Um, and then I think it would just be, hey, we're going to do what we can to support you off medication. If financial is the issue. And I'm hopeful that, the more and more we are in this space, the more options we'll have for patient, I forget what they're called, like patient assistance programs, rebates and things like that, and hopefully more insurance coverage. So Debbie, compounding is when, kind of usually any FDA medication can be compounded or combined with something else at a pharmacy level. The access to and supply issues of the GLP-1 medications allowed some level of compounding for a minute until the supply came back. And now they're saying it's sort of like illegal, but they haven't really been able to sort out how to deal with this. And part of that is that question of, once patients had a taste of the outcomes, even if it was from a compounded med that was a little bit maybe riskier, they don't want you to take that away. And for them, the risk benefit might be there. So I guess I always have this sort of, back to that evidence-based conversation. There's part of it is the evidence, which we can share. Part of it's your experience with others, but then really you've got to take that person and, like, they might be telling you, I'm desperate. I had success on this. I'm willing to take whatever the risk is. And I think you have to listen to that as part of the equation.
Nina,
Um,
can you address the muscle mass question? That's come up a couple times, and then
oh
you touched
yeah,
on it just briefly, but especially the one that we kind of got from the feedback from the June webinar.
yeah.
I think, let me just make sure emerging therapies, I think, is kind of what we're classifying it as. Muscle
Um,
preserving compounds, GLP medications combined with muscle preserving agents.
Yeah. So, I mean, the interesting thing looking at, I get to look at a lot of body composition data from the bioimpedance data that we have. And I think it's shocking to me that so many providers are willing to prescribe a treatment which may or may not have muscle loss as a factor without looking at their body composition first, right? I think we somehow think that weight or looking at someone or their physicality would be able to help us decide how they're doing and then get a body comp on someone. But I can tell you from the people who I've seen up front, really being able to look at where they're at to start, that should dictate how you work with them, right? And it's, even though we say all the time, right, like, here's your protein, here's your physical activity, strength training, like obviously in more detail than that, there's something about visualizing their own personal body comp that is really able to tie that together for patients. And so I think that is a big part of this. Talking about the muscle loss, and again, as I feel like you guys know me a little bit now, I'm a big communication, words matter person. The literature out there on what we're saying muscle loss is versus fat-free mass loss is so all over the place. Like, I want to write letters to the editor all the time because people are saying things like, the research says 25 to 40% of the weight you lose is muscle. So think about that. If you lost 100 pounds, that's saying you lost 25 to 40 pounds of muscle. Well, I can tell you for, even just looking at my own body comp, right? Like, my total muscle mass is more like 48 pounds. So losing 40 pounds of 100, again, that's some math that doesn't add up. But the point is, the 25 to 40% that they're telling you in these clinical trials is actually looking at a subset of the patients. So a small number, usually in step one, I think it was 140 patients who had DEXA. And DEXA, I know we talked a little bit about this, but DEXA is looking at lean soft tissue, which is if you take total weight and you minus fat mass and you minus bone, that's lean soft tissue. So that's everything. That's your muscle and water and connective tissue and skin and all this other stuff beyond muscle. So when someone's saying you're losing 25 to 40% of lean soft tissue, you might be okay with some of that other stuff going down a little bit as someone loses their total weight. We don't want them to lose muscle necessarily, but also body composition doesn't necessarily tie in the quality of muscle loss, right? So you're looking at, is it okay to lose a little bit of muscle mass, weight of muscle on the scale, if it's the lower quality type? And that's where I think we're going to see more and more data coming out from research on the quality of muscle and how we can assess that. And so I think that's a big part of it too. When you're looking, so that's DEXA. The way to really look at skeletal muscle is through whole body MRI, which nobody's going to do, but bioimpedance devices like ours is validated to that, meaning we looked at a big subset of patients, did their whole body MRI, did their BIA, correlation was 97% with a pretty low standard of error, and we feel confident that we can use this to approximate that for most patients and feel pretty good about it. So that's looking at skeletal muscle at a much tighter level. If you're looking at BIA, and I get this question all the time from folks who are using some of our, other BIA products out there, if they're validated to DEXA, they're probably giving you a little bit of an overestimate of skeletal muscle. So people like it better. They're like, yours is wrong because my muscle's higher and my body fat's lower in this machine. I'm like, oh, I wish that were the case. But it's usually muscle's about half of the fat-free mass. So you can kind of think about that on average. Like if someone's, saying, I can't really do the math, but if someone's like 200 pounds and maybe, so just say it for number's sake, 100 of that is fat and 100 is fat-free. Of that 100 fat-free mass, maybe 50 is skeletal muscle and 50 is all that other stuff. So that's the number that we're trying to get closest to. And that's the number that you would want to look at on somebody. So I think that's an important piece of this. Lots more information about that if you do want to chat individually about that. Of course, that's what I do now, so I can talk about that at length. Now, Leslie, there's so many good questions. I don't remember where I was, so tell me what you think is the next good, couple to get into.
Yeah, a couple came up about foods that mimic some of the GLP-1 benefits of the medication benefits. I'm not sure how much background or insight you have on that, but Elaine asked that question, and then a couple people upvoted it. So,
Okay, cool. I didn't know you could upvote in Zoom. That's
I
cool.
mean, thumbs up it. That's my
Okay.
version of upvote.
All right, cool. So I actually had a friend of mine who works in the supplement industry, Jacqueline Jakes. She's a doctor. She used to be in the bariatric space. I had her on my podcast to talk about kind of this because this is her area. And one of the things she said to me about foods that are mimicking GLP-1 that is very interesting is like many foods mimic that just in the foods we eat. She used the example of an avocado, right? So it increases that level for a really short time. And that's just pretty transient, right? So almost all foods can sort of increase that. I see that as a claim a lot. I have some friends who, neighborhood friends who I can't stop looking at their Instagram stories, even though I desperately want to, who are like selling some of these peptide-based products. And I'm like, but then I keep clicking and I can't unfollow her. But the claims that they're making are just wild because there's almost something so common sense about it that you want to believe it. And I'm like, no, this is not like what I know about science is this is not true, right? However, I think those I think that there's some space to talk about healthy foods that do that. But on the flip side of that, if a food were enough and effective enough to do this, we wouldn't have a pharmaceutical arm developing medication to do it. And a lot of it has to do with some of the science that's probably even above my head about the half-life and how long it lasts. And one way to think about that too is there's some new, pretty close to being out there medications that are, or even rebellious, right? That's the lower dose oral medication for diabetes. The dosage of that has to be so high and you have to take it daily because your body's sort of designed, I guess, to destroy the GLP-1 so quickly. I don't know if that's the right way to say it, but knowing that like the injectable is that way for a reason because that seems to be the best way to get something that lasts longer. I mean, we had uh liraglutide, which was a daily at a lower and like even that, it's people don't like the daily injection, right? So it'll be interesting to see how the oral comes out because people, of course, are like, I'd rather take a pill than a shot. But would you if it's daily and there's a lot more rules on how often or what you have to eat around it? I think that that will be interesting. So um, I would say, interesting to think about what foods are there, but the whole food industry, I mean, everywhere is, I'll be actually interested to see how that looks at Fancy even this year about products that are developed for GLP-1. I'm split on that just because it's cool. I mean, there's good food products out there that we can use and, smaller portions of things if we're saying that people get fuller faster. Like, I'm not going to argue with that. And marketing is marketing, right? They're going to use whatever trendy words are out there. But I think we just have to make sure it's science-based and we're teaching our patients to be critical consumers there. Um, I think
Nice.
I see two questions that I like here from Melinda. Is there enough differences in them that if you stick on one, it'll be worth trying another brand? I think that's really interesting too, because I've had a lot of even obesity medicine providers who were on medication themselves, talk about this. Like they started on whatever came out, 12 years ago, and they've tried the different ones. I think to some extent, you're going to be able to see something new with a new form of the medication. Like you'll see a little bit of, additional weight loss. So I would say it's worth trying. There's so many patient, um, like Facebook groups and things. I'm part of a few where I see that people really tend to have different responses. And I'm inclined to believe them in that way that some work better than others. And so for that person, I mean, again, if it was a perfect answer to every patient in a one size fits all drug, you wouldn't have non-responders and you wouldn't have that, um, bell curve in response. So I think definitely worth trying a switch. A lot of this is tricky with insurance though, too. Some of them have these like really tight algorithms that you have to do this to stay on it. After 6 months, you need a new prior auth. You've got to have lost 5%. And so I do think actually a big ask for the dietitians is that the better and more detailed your notes are, that can really help support the prior authorization process that the patient is doing all that they can from a nutrition or even an exercise perspective. So the detail there and the body comp data. I've had a lot of people, kind of talk to me about what do they put in their notes. They're showing somebody, who maybe didn't lose that 5%, but had a significant change in body composition. And I really hope that insurance does end up getting away from some of those stringent requirements because people might want to continue to take it based on prevention of additional cardiac outcomes. Reduction in food noise alone is such a like quality of life indicator for people who are troubled by that, that regardless of their weight, it really is something they might want to stay on long term for that.
Yeah, Nina,
Um,
I've also heard stuff about GLP-1s and reducing inflammation, which is a whole other conversation for, rheumatoid arthritis and different kinds of, those kind of rheumatic conditions that don't necessarily come along with having a higher body weight, right?
right.
So,
I do think that maybe this, is, and as you're saying that, that does remind me a little bit that the more and more studies we have out that are kind of in these non-weight based conditions, the more likely we are going to be at sort of equalizing the conversation and getting it away from just weight as the only indicator, which I think is really the beauty in in this area of time is just being able to say like I'm on this for its prevention effects for the conditions that I have. And so I think more to come. It's a honestly, it's an exciting time to be a dietitian because there is such a kind of interest in how nutrition plays a role too. And I think we can do even more at putting ourselves at the table at these places of, even when people are being biased about weight, well, nutrition really is important at all the stages of that.
yep.
Um, okay. I see there's so many good questions in here. This is the other one. Elaine had asked. I heard some people lost ability to enjoy eating. I think that's a big one, right? Because there's really this is a thing I think we should definitely be talking to patients about is sort of the goal is not to have zero appetite. The goal is not to never want or enjoy food. The goal is really to kind of have this balance between, reduction in extra adipose tissue and enjoyment of food. So I think this is where we can kind of finally come in. I've looked at the medications as like we're able to finally remove that noise and that clutter around this is what I'd want to do, this is what I'm trying to do, this is what I've done in the past, but this always got in the way. And if we're removing the biological this that's always gotten in the way for them, they're much more open to being able to do the nutritional planning and things that we generally get to talk about. And so I think it's a really good time for us to be like, we get to be the good guys here. We're not the taker awayers anymore, which is what so many people have had experience with a dietitian for in their past. So, but I think that it's also such a tricky space that people think you're going to take away their medication if they report any negative symptoms. So being able to be that person that's like, on a comfortable level where they're willing to tell you stuff, that's big. But being able to sort of like, I imagine it almost like when you tell your kids, mine's 11, so I'm not here yet, but like, hey, you can tell me anything. If you're at a party, I'll pick you up, no questions asked, right? Like, hopefully I can do that and not do the things that you want to do instead. But here it's like you can tell me anything and then like have them report their symptoms and not say, say the medication's immediately coming away. You want to be able to say you want to enjoy your food. So there's ways that they can dose change and sort of balance all of these things. And that does probably lead into a little conversation around the disordered eating and some of the concerns people have is that we have to remember that we never can really control our weight, and that shouldn't be the focus, but we can control the things we do each day. And so people probably get a little bit of a false confidence that they can control their weight because it does seem to be in response like I'm taking this med, I'm increasing the dose, the weight loss is coming up, so it might feel like they're controlling this outcome. And so I think that always is a point for us to come back and talk about that the number on the scale is not something that we can control. We can control what we do every day in our behaviors, and enjoying food and having things in your day that you like is a part of that. So we've got to sort of balance how we can get both of those things together and not you know have that be an imbalance.
So we have
Uh,
time for it's just after 2:30 here on the East Coast. I want to respect everyone's time because we did set this for about a half an hour. But Nina, if you want to stick around and anyone who can stick around wants to, there's a couple more questions that came in. Nina, if you have the time and want to address them.
sure. I like the question by Dana, the question here that's about,
I was
protein
just about to.
recommendations. Is that what
Yep.
you were going to call out?
Yep.
It's such a tough one. And I know Joan did a good job presenting this in the initial webinar of like, here's what we have for guidelines right now. If you really dig into the guidelines, a lot of it is even still clinician experience out there because we don't have really well-designed studies that test these levels of protein. I always I mean, just like you pointed out here that, are we using adjusted body weight, ideal body weight? Is that to a BMI of 25, or is it the Ham-Wee equation and desired weight? Like, it is so tricky to figure that out, which to me means we're really not even close yet to be able to exactly give someone that recommendation. But I think when you're the human, calculating like grams per kilogram is not at all a number that means anything. And the space between, kind of like in bariatric surgery, what you're recommending and what the person's actually able to do might be so vast that the recommendation is kind of meaningless, right? So I think it would start with getting an assessment, of how much someone's able to eat, and then sort of retweaking that around making sure that of the eating occasions that they have, they're able to get in protein at most of them. I think also there's more of a place for protein supplements with the medication world than there was for me in bariatrics. Supplement protein shakes or whatever were always liquid. They always went down easy. They didn't fill the person up. So I'd use them when someone was really struggling to get in enough food. And here it's often like kind of in a similar way where you're trying to say, how do I get in enough protein when the foods are not, when I'm not that hungry, when I'm not able to eat too much. We don't want to recommend like overeating past a point of fullness just to get in protein. And we want to remember that protein is a component of food. I think people so much think about like protein is just this, I don't even know how to describe it, but not a food like, oh, I get my protein and I drink my protein and they think about it that way. So I think bringing it back to the food, but then being open to the fact that a supplement might be needed if that is their goal, and balancing that with your body composition data to say like, hey, here's where you're at, here's where you're trying to be, let's see what the data says. Maybe that's enough for that individual to prevent any further loss, or maybe it's not. And so I wouldn't do it blind. I would have the data, to test out your experiment. But yeah, I mean that latest paper that came out, the Mozafarian paper that was 17 people, only one being a dietitian, who they kind of went on some, recommendations that are out there, not exactly a study on protein, but theirs was, I think, 1.2 to 1.6 grams per kilogram of fat-free mass. And so that throws another kind of wrench in it that to get someone's fat-free mass, you'd have to know their body composition. So I like that recommendation because that supports, doing body comp in practice. Um, Hard to say. I really have seen people recommending adjusted, ideal, actual, all over the place. So I would say we're in a way not that much closer to a targeted goal, but that does support listening and talking to your patient and seeing where they're at. And so the individualizing of that um is pretty important. So and Melinda shares her personal story here of being on Ozempic. When I got to 1 milligram, I couldn't eat at all. Animal protein made me sick. So this is a super, super responder, right? That sounds a lot to me like some of my surgical patients where animal proteins did not work for them afterwards. And so they resulted to all these slider foods, right? The soft and slippery foods that don't sit in your stomach, low in fiber, low in protein, peanut butter and cheese crackers, fruit. Like I did so much work with patients in that category. Lost a lot of muscle mass and gained weight back. That's a extreme story, I think, but hopefully not too common. But that can happen. So that really to me highlights what was your muscle mass before, and going slow and up on that dosage to where you can tweak it to a point where it's enough to help you with your goals of reducing adiposity, but not I mean, that's zero food enjoyment,
Mhm.
I'm sure. And so kind of balancing that. And in that case, maybe that is a reason that someone might need a lower dose than the lowest dose available to achieve the outcomes that you're looking for. So,
Yeah.
um, yeah. Did I miss anything big in here,
I
Leslie?
don't think so. I think you've got most of them, if not all of them. You did the body weight. We talked about other food-based GLP-1 triggers. Oh, the one that someone did mention, impact on eating behaviors, and we had that actually in our list as well.
Hmm.
So the question that we received from the June webinar often was, are GLP-1s triggering disordered eating behaviors? Um, but then there's also considerations about what is a healthy weight? What should you be expecting to lose or to gain back if you're on these medications? Keeping it off an acceptable amount of weight regain. So lots of considerations there, but can you comment on the eating behaviors, eating disorder behaviors that you kind of have been seeing or know about?
Yeah, that one is definitely tricky because I have a friend who calls this like the biggest social experiment in medicine, and what I'm thinking of first is just it's so different in that patients can get access through compounded pharmacies. I mean, I saw something over the weekend that there was at a barber shop or at, there was some weird place where they were getting medication. Like, so if someone's got dysfunctional disordered thinking around their body size and weight and wants to procure a medication to help them lose further weight, I think the access there is something that toothpaste is out of the toothpaste tube on that, right? Like there's access. So the hope is that they're connected with enough of a comprehensive care team that can sort of identify that type of behavior and be able to, kind of bring them back. So to me, that would almost advocate for, again, another reason why we want medications to be uh, prescribed um, in the healthcare setting is that it would be like hopefully the healthcare providers are taking a look at the risk and benefit and deciding like, hey, this is someone who, while their body size might be higher and while objective data might say they need to lose weight, we know that there's all this other stuff going on. So I think if you're seeing a patient and you're a dietitian, your role could be really helping them, get the counseling that they need from the professionals to be able to manage that side of it. But it's tricky because once people, I mean, in any way that they've been able to lose weight, once they lose that weight and they feel maybe better and they want to keep doing that, at what level do we get to where we're saying, okay, now we've got to stop the thing that helped you, right? And this comes up with insurance. I talk about insurance a lot. That used to be my whole world as a bariatric coordinator. Um, but with insurance, like sometimes once you get down to a certain weight, they might say, well, you don't have obesity anymore. You don't need an obesity medication. Just like with blood pressure, right? Once someone gets to an ideal goal, we don't take away the thing that helped them get there. But that's sort of where we're at because, again, using weight only as the outcome puts us in that situation. So, I don't really have the answers from the disordered eating area other than to say it's really important that you're on that person's care team, that you're kind of looking at that person's individual case and saying, this might be tipping the scale where it's not healthy anymore. We might have to come down on the dosage. We might have to increase the nutrition, exercise to sort of balance everything out. But um I think it's important not to be judgmental and shaming in your approach because then they just won't tell you, right? So I do love that about my fellow dietitians is that we tend to be approachable, that patients tell us everything, right? So I like that in this area because they might tell us stuff that they might not tell the doctor, and that can help us get them into counseling or into a place where they could get some help for something that might be beyond our scope.
Yep. Excellent. Well, I think that's a good note to end on. It is 2:45 here on the East Coast. That's all the time we have. A little bit more of time, which is excellent. Thank you so much, Nina, for joining us and bridging the learning gaps on this very important topic that just keeps becoming more and more important and more complicated. We appreciate your insights.
Yeah, this was great. Thank you guys for really good questions. This was definitely that piece that you miss when you're in a bubble, just talking to the webinar sphere. So
Yeah.
appreciate that. And Leslie, I don't know if you share my contact info, but I'm happy to share that in any follow-up if anyone wants to keep talking.
Yeah, if you want to pop it in the chat, that's actually probably the best
Sure.
place to put it. And then I just want to say thanks everybody for sticking around. This was a great session, lots of interaction, lots of great questions. We appreciate you signing on. We're going to offer more conversations like this one, including extended Q&A like we covered today, as well as deeper discussions on specific topics and conversations about what's working or not working as you integrate interprofessional care strategies into your practice. I know there were some questions today about referring out to other doctors, how to stay abreast on all the data that's coming out about GLP-1 specifically, and speaking intelligently about that, where, doctors are not necessarily well versed in nutrition like dietitians and other healthcare practitioners are. So we're going to talk about this stuff more. If you liked today's session, even if you didn't like it, tell us. You can provide your feedback. Go back on the website. There is a survey there, just a regular looking evaluation as you would do for any 4 credit session. But just jump in there and tell us your thoughts, your feedback, and what you want to learn more about, what other offerings you'd like to see from us, because we always are welcoming any ideas. We're open to all of them. So
Thanks for doing this.
everyone,
This was fun.
yeah, have a great afternoon. Thanks again, Nina, and we'll see y'all next time.